You'll be speaking on evolving paradigms in MIGS and tubes in angle closure disease. Over to you.
Both of you have to. Thank you so much, Dr. Kirti, for making me a part of this wonderful group. And I will focus on whether you have enough space in angle closure to be able to perform a mix. And happy to be a part of this wonderful group of stalwarts. I will also be touching upon just briefly on a few tips about implants in angle closure. And now, when we talk of this topic, why do we think there is a challenge especially related to MIGS? First thing is whether you have access to the Schlem's canal and whether the iris root is visible or not. That will depend on the extent of the peripheral anterior synechiae, how large is the lens, how is the lens vault, and whether you're taking out the lens before you perform the MIGS or not. The iris in our eyes is different. While you see the Western eyes accepting sutures, trabeculectomies being performed without PIs, our iris is not like that. So you will have much more inflammation. There is much more higher chance of spas forming, and goniosynovial lysis is not been as effective as it has been in the other populations. Also, a lot of our eyes have persistent closure after PI and even after cataract surgery because of plateau iris syndrome. So just goniosynovial lysis may not work there. So with so many challenges there, is it even worth performing MIGS? I believe if the schedules were drawn just a week back, looking at this review article, I would have not needed to give this talk. This paper has just been published for me to pull everything out from there and present before you. The wonderful thing about this paper is, this review meta-analysis is, they have excluded 43 papers and included only 12 high-quality papers, 3 of which are randomized controlled trials. Now, with every paper that we read on MIGS, which support MIGS, we have been talking about where is the RCT, where is the evidence, what is the quality of evidence. So we have some evidence here. Let's look at that. But the meta-analysis showed that when you combine MIGS with phacoemulsification, you get a 10 mmHg drop which persists over 2 years. So all these studies have significant follow-up, and the number of medications reduces by 2. And this is seen across the kind of MIGS that is being performed. Of course, it is higher for some rather than being equal in all of them. Now let us just look at the 2 randomized controlled trials. The first one from Song et al. It was a multi-centered trial. You can see the names that is involved here, big names across various nations. And what they did was randomized 124 eyes, 65 and 49 to phacogoniotomy with a Tanito hook, and 59 to phacotrabs. So they are taking up not only phaco but phacotrabs. And as you can see that the baseline, with a similar baseline, they have also presented the per protocol and intent to treat analysis both, and they see a significant difference in IOP at 12 months in both the groups, which is similar. So phacogoniotomy is working as well as phacotrabeculectomy in both intent to treat and per protocol analysis. And you can see that in these graphs also. Of course, the number of complications that you have had in the goniotomy group were lesser than that in the phacotrabeculectomy group. Another study from group in Egypt which has published a very good paper with successful outcomes after GATT, and phacotrabeculectomy versus, phaco versus phaco and GATT, and you can see that the success rate is much higher, and the number of patients who are off meds at the end of 1 year is also much higher, 75% versus 42%. So phacogoniotomy or phaco-GATT, they work as good as a phacotrab in angle closure and much better than phacoemulsification. So what about ECP? I believe there are some studies which have published good result, and especially in plateau iris it may have a space. What is our experience? So this is not evidence till it gets published. So this is experience rather than evidence. You can see this patient with uveitic glaucoma of a very recent onset viral etiology, uncontrolled intraocular pressures. Now, this is not how you should be doing a goniosynovial lysis. I am using an MVR. I got away with it. If you land up into a hyphema, please don't blame me for it. I'm spreading the wrong word. And if you have access to even 2 clock hours of the angle, the Schlemm's canal, you can actually start doing a GAT. This one actually got stuck, and I had to kind of do a twin pass. And as you see here, this is taking time. So instead of a 4-5 minute GAT procedure, you can actually, you will need much more time. And at the end of it, because this was a phakic eye and you need pilocarpine to start acting right on table, I have injected pilocarpine here. In milder cases, I prefer to do either a bang or KDB goniectomy. And you can see here the trap meshwork being peeled off very successfully and easily. And because the angle was quite open, this was a PAC, not a PACG. And on retrospective analysis of 48 eyes who followed up for at least 6 months, the success was defined as 21 millimeters or mercury less intraocular pressure, along with 20% reduction in IUP, along with reduction in 2 AGMs. So all these 3 criteria had to be fulfilled. And out of 48, 23 had greater than 1 year follow-up. 95.8% of the eyes met the success criteria. Most of them had combined phacoemulsification. Intraocular pressure reduced from around 23 to around 13, the mean intraocular pressure. The medications reduced from around 4 to 1. And 85% of patients had intraocular pressures less than 16. 65% of them had intraocular pressures less than 14. 23 out of 48 eyes were free of medication. 2 eyes, however, needed further glaucoma surgeries. In my opinion, and I take full responsibility that this is only my opinion, not all angle closures are same, and before considering a MIGS surgery for these patients, you should look at the degree of plateau iris, degree of PAS, whether it's a plateau iris or not, the contribution of the lens, how much is the phacoemulsification going to contribute, and the extent of disc damage, because your target IOP has to be met, which may not always be the case with MIGS. There is a lot to promise, and the advice is to combine it with phacoemulsification. If you do a minimally invasive bleb surgery, perhaps it may be a good idea to use an iridectomy also. Implants, I would say, may not be a very good idea in our eyes. Now, moving to another set of implants, the biggest challenge that we usually face when we perform a surgery in patients who have angle closure is going and hitting the iris. Now, despite whatever you do, because you're trying to go into the sulcus or sometimes in vitrectomized eyes, even behind the intraocular lens, you are likely to hit the iris. So, you, instead of going and changing your track, one simple thing can be to actually go and cut the iris wherever it is hitting the iris using a vitrector, or as you see in this video, just a simple micro scissors, and that can give you access to the anterior chamber and establish a good flow. This hitting of the tube, the tube hitting the iris may not always be avoidable if there is extensive PAS. Also, a lot of eyes, like long-standing angle closures, patients with plateau iris, patients who have had previous aqueous misdirection, and if you have a non-valved implant and you are removing the ripcord, may have shallow ACs, which may predispose to aqueous misdirection. So do not forget strong cycloplagia with atropine and probably combined with iTrop plus. So opinions and RCTs are always invited. Thank you so much.